the before of the reporting in reporting of the spinal imaging. Speaker is Professor Stephen Wong from Singapore. He's working in Sekang General Hospital. Yeah, Professor Stephen Wong is a very experienced in the musculoskeletal, and now he will present to us the topic is the people in the reporting of the spinal innovations. Thank you. Please.
Thank you very much, Chairman, and thank you very much for the kind invitation to present at the 25th Congress of the Vietnamese Society. So these are my disclosures. And let's start. Okay, so basics of spine reporting, you need to know the nomenclature, whether it's a bulge versus a protrusion or extrusion, and which zone. If you can, read this article. It gives you all the various variations. My preference is for a disc bulge, generalized protrusion in all directions or in one or two directions. Protrusion usually broad base, generally where the base is wider than the degree of disc protrusion. Extrusion usually is a narrow neck, but in addition, if you're a spine surgeon, you need to look for whether there is a break in the annulus fibrosus. Let me see. Right, so you can see the break in the annulus fibrosus and where the disc has extruded through. So the spine surgeons look for that before they will call it an extrusion. All right, so the other zones, these are the zones, the nomenclature I prefer using. Obviously, your institution will have variations as well. Currently now, paravertebral is at the lateral aspect. Paraspinal is at the back next to the spinous process. All right, okay. So, and the subarticular zone, or what we used to call the subpedicular zone, is really because the surgeons, when they see it, the patient is prone during surgery and is immediately deep to the facet joints. So they call it the subarticular zone for the surgeons. But for us, you know, it's actually here. Over here, right? So this is a true event, and I hope it doesn't happen to you. So nomenclature is very important. Numbering of levels is also very important as well. Right, so this is what a normal MR spine should look like. In my hospital, we use a sagittal T2, T1, and term. And this is what the axial should look like as well at different levels as well. If you can, especially for scoliotic spine, do a coronal T2 sequence. Some hospitals like T1s. I have no problems with that, but I like T2s so that you can look at the nerve roots as they come down to the spinal canal and as they exit the spinal canal. And the coronals also help you look for places where there's muscular trauma in the paravertebral and paraspinal muscles. Always look at a routine x-rays at the same time as you look at the MRI. And if they are obliques, even better. Oblique x-rays are very helpful when you want to look at the places like the posterior lateral corners and when you want to look for Powell's defect. For CT scans, so we've got requests for reformats from CT abdominal and pelvis. So usually we will try and reformat into coronal and sagittal plane. So here's a patient that we thought was, the surgeons was concerned about infection, but to us it's just degenerative changes at L4-5 level. But once you have a coronal or sagittal reconstruction, you can see the degree of anterior listhesis and the destruction of the end plates in the area. And if you have previous CT scans, always look at them for reference. You may pick up the odd deposit or fracture. Numbering is very important. Unfortunately, most patients don't read the textbooks. Okay, they don't know that they're only supposed to have 7 cervical, 12 thoracic, 5 lumbar, 5 sacral segments, and there's also variations. So when you do the numbering, you have to count from C2. We will always do a full whole spine sagittal localizer, as in here, and we will count down from C2 level down all the way to S1. Our technologists will do labeling, but then the radiologists themselves will also come and do the labeling, numbering ourselves as well. All right. There are other pathologies present on the localizer sequence. We've picked up tumors, we've picked up fractures and infections in other places in the abscesses as well. So do look at those. So here we have a 27-year-old with back pain. And the problem is you'd want to number properly. Okay, so have to look at the X-ray because the localizer sequence will only show especially in a scoliotic spine, will only show the vertebral column in sections. So refer to the X-ray as much as you can, and you count the number of ribs when you're in doubt. Okay, so if you have sagittal, it helps. But once you have a scoliotic spine, it's very hard to get the entire spine in one image. So refer to a chest X-ray and the lumbar spine X-ray, and then you do the counting from that way down, and then you can get the level of changes. So in this one, you can see that there is perhaps a L5S1 transitional vertebral body, which is sacralized, very common, about 25 to 20% of the population has this. There is a established classification. Most common would be the 2A and 2B, where you have unilateral or bilateral large L5 transverse process that are articulating with the sacrum and causing pain. The clue on the axial is that you have a large bony mass on the lateral aspect of the vertebral body, and it's enclosing the anterior neuroaxial canal. And this can be the one that's causing the nerve root impingement also. Right, so here are just further examples. You have a sacralized L5, partially right-sided, Castelvi type 2A, all right? And a lot of variations, another patient with and pseudo-articulation on the left side. Right, and if you scan down following axial, you can see the large left transverse process that is fused and is a huge bony mass, and it can actually cause problems. And there are a lot of structures that pass through. It's not just the nerve roots. Sometimes it's the spinal arteries and spinal veins, and those can get engorged and cause obstruction, impingement on your nerve root. So another patient with radicular pain, you can see this patient has a lumbarized S1 there, transitional S2, and a lot of vestigial S1-2, S2-3 disc, right? So without counting the spine, you can actually mislabel the level, and when the surgeon wants to do a surgery, he's going to encounter problems for him. Always look at the extreme most sagittal images if you can, because it shows you the position of the nerve root within the neuroaxial canal much more accurately than if you just use the axial. So I train my trainees to look at sagittal at the same time, or rather to look at the sagittal images first, before they even look at the axial images. Right, and this is just one case where we picked up, and there was a malignant ovarian teratoma on the planning sequence here. And I used that for an exam case, and everybody missed it. Right, so there are a lot of normal variants. You have a C5-6 block vertebrae, and most important is you need to report the fused posterior elements. The neuroaxial foramen here is narrowed because of the fusion. But it's a congenital thing, and it's not an acquired problem. So it's very hard for the surgeon to do anything about it. On MR, you can see the smooth posterior vertebral column over here that shows that it's congenital rather than acquired. All right, and you can see the fusion on the side. Spina bifida occulta, everybody knows to look out for. The other entity is the vertebral limbus, which you see here, and it's just a development anomaly here. don't mistake it for a disrupted or a valve end plate osteophyte, okay? And the anterior longitudinal ligament will be attached to that one. Other normal variants, if you have a look at the flexion extension, C1, C2 looks a bit odd. CT scan was done, and we made a conclusion that it's actually an os odontoideum. It's a normal variant, likely due to failure of fusion congenital in the early phase. Right, so as MSK or spine radiologists, we like to only look at the bone. We don't like to see the soft tissue structures in front of the spine. So invariably, we will put a huge saturation band in front. But sometimes the saturation band is too close to the spine, and you lose information on what the pre-vertebral soft tissues are like. You have to try and avoid that because you don't want to miss the thyroid tumors, the laryngeal region tumors as well. Right, let's go to the spinal cord. Spinal cord can have a lot of problems, right? But sometimes it's abnormal, right? So if you see this, and you do a contrast study, contrast MR, you will see that this doesn't enhance. It's likely to be a normal central canal, a little bit dilated. Don't call it as a strings. But you're going to have problems in patients with a history of compression of the spinal cord over here and here. Is that a dilated spinal canal as a result of compression and volume loss of the cord, or is that gliosis within the cord because of the compression? Sometimes you just have to do sequential follow-up MRI scans to see whether that degree of signal change or cystic change persists or gets worse. Right, but as you can see, if you do progression and changes, you will see the signal change within the cord, the degree of compression, and over time. Right. The other entity on MR, we all look out for the widened C1, C2 joint on X-rays, especially if the patient has rheumatoid. But somehow we always forget to look on it on the MRI, sagittals. There are some departments in Singapore last time where they didn't even bother doing axial of C1, C2 for the MR. But we've stopped that because we missed a few. Just remember the normal indices of 3 millimeters for males and females, but in children, can be up to 5 millimeter. Okay. So alignment or subluxation of the vertebral body. The Meyerding classification is the one that most people used, and it goes from grade 1 to grade 4, and I'm sure you're very familiar with. I've only ever seen a grade 5 once in my life, right? Patient was obviously paraplegic, and it was a congenital thing. Always look to see whether there is any pars defect, but the main thing is if you see the sagittal MR and you see that there is anterior listheses. So what happened is during anterior listheses, your neuroexit foramen changes shape, becomes flattened, and becomes slanted forward. And this means that your nerve root has a much more horizontal course over the exposed components of your intervertebral disc. And because we do our scans with the patient lying supine, you don't know the true degree of anterior listheses or anterior subluxation. If the patient actually stands up, the subluxation may be worse, and the space available for the patient in the standing position may be even less. Right, so this is something you need to bear in mind when you see this. Always mention that the neuroexit foramen is narrowed and flattened because of the anterior listheses. Okay, so here's this another case. Sometimes it doesn't just sublux in the anterior posterior direction, especially in the scoliotic spine or post-infection, you have lateral subluxation as well. And so the subluxation is in multiple directions, and that information needs to be conveyed to the surgeon. So here you will see that because of the lateral subluxation on here, this exiting nerve root is now possibly affected, and his friend on the other side may also be affected because it's now stretched because of the lateral subluxation. Okay, so if we follow down, you can see, you can take note of the position of the spinal cord. It's very important, especially when you see a case of subluxation. And as it progresses down, you can see the cord gets affected. And the position of the cord in the final, where the chorda equina is, or the cord within the spinal canal alters. The cord and chorda equina will go through the straightest route despite the degree of scoliosis or subluxation that your spine has. So spondylolysis, something we are all familiar with. You look out for the pars defect over here, and then invariably you will have anterior listhesis, anterior subluxation because of the instability. It can be congenital, can be acquired. I've only seen it at L4 and L5, and I've only seen it once at L3 level, but that one was post-traumatic. So it's something that we were looking for. All right, so once you have that, then you actually need to refer to the x-rays, because x-rays are better at showing spondylolysis than MR. MR can be quite difficult, and sometimes if you're lucky, your MRI technologist gives you a very nice image, but most times it's in between, there's partial voluming, and it's actually quite difficult to make it out. Right. So let's look at some disc. So the disc can do whatever it wants to do. So you have different types of disc protrusions. In the cervical spine, you want to see whether the disc is still below the posterior longitudinal ligament or otherwise. Okay, so if we have a look at this one, on here at this level, the disc has actually come out in the lateral aspect. And instead of going anterior posteriorly into the spinal canal, it now goes into the left neuroexit foramen. The clue is there is no CSF here. So there's no bright T2 CSF. This was actually missed by one of our residents, but we picked it up when we checked the MR scans. All right, so in here, sometimes you have narrowing of the neuroexit canal by osteophytes and other entities as well. All right, so the disc will go wherever it wants to go. Most times it just goes anterior, posterior, beneath the posterior longitudinal ligament. I will call it a subligamentous disc protrusion. Nothing to worry about, okay? Just report it, surgeon's quite happy. Sometimes it goes laterally, like the one I showed to you, and it goes into the lateral region of the spinal canal or into the neuroexit foramen on either side. This is the one that, as radiologists, we need to pick up on. It's very subtle. You can see a very small hint of it here. The nerve root is not very happy because of that. The ones that we definitely need to pick up on and emphasize is when it has an anterior-posterior subluxation, but there is a split in your posterior longitudinal ligament, and it goes through your posterior longitudinal ligament into the epidural space. This one is almost impossible for the surgeons to operate on, and they end up having to do an ACDF for the patient. All right. So this one you have to pick up on, and you can see the split in the, hang on. You can see the split in the posterior longitudinal ligament because of that. Right, I'll just push on a little bit because we're running out of time. These protrusions on x-rays, there are very soft signs like blunting or beaking of the end plates. But usually you need MR correlation for that. CTs may be helpful, but you have to play around with the windowing. If you only have a CT scan, the patient cannot tolerate an MR. You have to play around the windowing. This is actually CSF windowing, And this one is actually abdominal windowing and not bone windowing, just to look at whether there is disc protrusion or not. Sometimes you have to decide, is it a disc or a nerve root? Because occasionally you will have two structures here. And this is where the sagittal comes in. All right, the sagittal image will help you decide where the low signal intensity structure comes from, and is it a disc protrusion that has extended caudally or in the cranial direction. And you also look for missing CSS space or missing fatty tissue space. So here you have the nerve root, and here the thecal sac and nerve root here, and your nerve root is here. It is actually disc protrusion in this area. So, like this one I showed you earlier, this is the one that has gone laterally into the spinal canal. All right, and this is the annular fissure, and the position of the annular fissure is quite important. Don't miss out the epidural lipomatosis, not that common, less than 5% of patients, but sometimes there are clues like tethering of the cord. But it does impinge on the movement of your cauda equina and your nerve roots once they exit from the thecal sac. Okay. Right, so here is quite an extreme degree of epidural lipomatosis at L5-S1 level. Sequestration, we all know to look out for it. It's not as easy. The easiest one to pick up is when it's in the anterior aspect of the spinal canal, but it can go in any direction. And in this case, it's actually gone out laterally and gone into the posterior aspect of the spinal canal. And it took us a while to work out where it went. Initially, the reporting radiologist thought that it was a tumor or glioma or something, but we traced the sequences. But not everything is a sequestrated disc. Sometimes you will see a small dot, a low signal intensity dot within the spinal canal. You can see where the arrow is. If you give contrast enhanced, it's likely a glioma, incidental. Most times the surgeons say leave it because it costs more trouble to go and take it out than leave it in there. All right, so let's skip on. OPLL is simple. Get a CT scan, look at it. The degree of OPLL is well reported. MR may actually underestimate the degree of stenosis of the spinal canal. And then there are different sort of OPLL, each with its own complexities and complications. DISH is another condition. Apparently very common in our population in Singapore, and I'm not sure about Vietnam. But in the Asian population in general, you see more DISH and OPLL than you see in the Western population. And if you can ossify your posterior longitudinal ligament, you can ossify your anterior longitudinal ligament. The clues is that the intervertebral disc spaces are not affected in DISH. They usually have a normal height, but there may be breaks within the ALL or ALL. Okay, you look out for cervical region more, but it can extend down the entire spine, right? So here, CT is actually better for demonstrating OPLL and DISH conditions. But you do the MR for the cord. Okay, 2 minutes, I can hear the beep beep, okay? Right. So X-rays are also helpful. This is a case with TB spine, and you can see the paravertebral swelling in the mid to lower thoracic spine and the collapse of the vertebral body. And CTs and MRs are just help for you to diagnose and localize the extent or spread of the abscess and instructions. Sometimes they're very subtle, right? A loss of the corner of the vertebral body, which I'm sure we are all very used to looking at. And here it is here, and this is the vertebral body that's affected. And you want to pick it up at that stage before it causes any further damage. If you just look at the frontal image, you can't see the erosion that clearly. So both lateral and AP views are needed. Mets, we get asked constantly, is this a new met? Is it an old met? Sometimes I can't tell. You just have to go back and look at as many imaging studies as you can, CT scans, X-rays, whatever you can find, to see whether that is a new metastatic deposit or not. And is it, if it's a multifocal, is easy. Okay. X-rays again gives some information, but not enough. In this patient, X-ray is fairly normal. It's just L4-5 and L5 that looks a little bit more hyperdense. But once you do the MR, you can see a very mottled, permeative appearance to the marrow. This is actually early on-stage multiple myeloma marrow changes. It becomes a little bit more homogeneous in the second and third phase of the disease. Right. Okay, so infection, okay, another 2 more minutes and I'll finish. So we saw this one earlier where if you do additional studies and reformats, you will see the infection in the disk spaces better. Okay, so for trauma, consider weight-bearing views. In this patient, unfortunately, the degree of instability was missed in the initial setting when the patient came for clinic and did the X-rays with the, oh my word, the degree of cell luxation is worse than before, and we rushed the patient for MRI. I can see that there is cord compression at that time. All right, and this is the last few. In a case of spinal instrumentation, this posterior marker moved out and is now within the spinal canal. Right, a lot of people don't pick that up. But now, which means that the spacer the surgeon has put in is migrated out of the disc space into the spinal canal and is pressing on the nerve root or pressing on the coda equina. You have to pick it up long beforehand. So the normal positioning is 2 to 3 millimeter from the posterior margin, and there will usually be a check X-ray after the surgery for you to determine the position, the original postoperative position of the spacer. Right, if you have surgery and then unfortunately you have pain, it means that your disc protrusion has come back. There's no way for the surgeon to close off the hole, right? So if the patient complains of pain post-surgery, do an MRI, look for abscess, look for fluid collections, or see whether the disc protrusion has recurred. And finally, I'd like to end this, which is a cyst, which is not a cyst. This is a synovial cyst from degenerative facet joints. These are perineural talus cysts. These are schwannomas, paraspinal AVNs in the spine. So not as easy as you think it is. I actually have an entire talk on talus cysts I can give another time. So this is just a taster. I will try and end my talk. So spinal imaging is not as easy as we think it is. If you can, look at the sagittals with as much attention as you look at the axial sequences. Look at the X-rays and look at the CT scans also. And if you need to, give intravenous contrast medium and see as many previous imaging studies. And with that, thank you. My apologies for going over time.
Thanks so much for your presentation of the spine imaging. The spine imaging is very frequent per day in the Israeli department, so I think it's very useful for us to consider how to have the prevent and the before and the artifact before of the interpreting. Yeah. You have some question? Chúng ta có một vài câu hỏi. Xin thời gian ngắn, xin mời.